Hello world, my name is Dr. Shaham Das. I'm a consultant forensic psychiatrist and I live and work in London. I assess and rehabilitate mentally disordered offenders, or what the tabloids might call the criminally insane. I regularly assess defendants in courts, in prisons and in special secure psychiatric units that are reserved for the most dangerous and violent patients. Although I specialise in criminal psychiatry, I've also got expertise in most aspects of mental health. And this video podcast series is going to explore a range of mental health topics. It's designed for the layperson who might be interested in learning more about severe mental illness. And sometimes the material is going to be about how this relates to offending, although sometimes it won't be, but it will all be from the perspective of a psychiatrist. I'll be talking mainly about severe and chronic lifelong mental illnesses that really hugely impact on the sufferer's functioning, like schizophrenia, bipolar affective disorder. This particular episode has my very first guest, Lucy, and I'm going to interview her about her experience of dealing with mental illness and of self-harming. Lucy's also going to talk us through the process of being exsectioned, and then we'll focus on what life was like for her on a psychiatric unit. And Lucy's had around 4 or 5 psychiatric admissions, so she can really give us a real insight. I hope this episode is not just interesting, but I hope it might answer questions or at least alleviate some concerns for anybody who might be facing going to a psychiatric ward, or for anybody who knows somebody else that's in this kind of situation. I'm going to open with my interview. I found Lucy to be honest and frank, and she didn't sugarcoat her experiences at all, which certainly made it more raw for me to hear as a psychiatrist, but hopefully also made it more helpful for you, the listener. Then afterwards, I'm going to tell you a little bit about life on a psychiatric unit, so what it entails, what the usual routine is, what the actual function of a psychiatric admission is. And then I'll discuss the various members of staff who work on a ward and their individual roles. And at the end, I'm going to let you in on some of my personal thoughts and insight from a psychiatrist's perspective. Specifically, what a well-run ward looks like, what a well-functioning ward looks like, and how to create a supportive environment. But I'll also tell you about what a malfunctioning ward looks like, because trust me, I've worked on plenty of those. I hope you enjoy the podcast, and welcome to So Lucy has very kindly agreed to be my very first guest on my podcast. She has experience of mental health issues, including low mood and deliberate self-harm. And Lucy has also been admitted to psychiatric hospital on several occasions. She's also a freelance writer who writes about a range of things, including mental health issues. So in my career, I've sectioned people, I've treated and medicated people, but I thought it'd be interesting to get the perspective of somebody that's been through it all. So Lucy, we're very interested to hear your stories and to hear your experience.
I'm glad to share it.
Thank you for coming on.
No problem at all.
So I think my first question would be, when did you first notice that your mental health was an issue, and what kind of experiences and symptoms were you having?
I think my mum would say that I was an anxious child right from the toddler years up. Certainly, I remember being probably 6 or 7 years old and her taking me to a homeopath because I was having such bad sleep problems, which I think must have been quite wearing for everybody. Although I was quite academic, I was very reluctant to go to school when I started. On one occasion back in the 80s, which would definitely not happen now, but I was able to get out of the school gates at lunchtime and walk home by myself because I found it so difficult being sort of away from home, away from my parents. And then in terms of a first diagnosis, I was about 15 when I first went to my GP on my own and said that I thought I might be suffering from depression. And as a result of that, be prescribed antidepressants, and that was really my first encounter with mental health services.
I mean, that's a big deal for anybody to have to deal with, but especially as a 15-year-old, you're not fully confident or fully grown up. It must have been really difficult.
And this was sort of early 90s, so we've come such a long way in terms of openness about mental health, but back then it really wasn't something that was talked about. Yeah, for example, self-harm became an issue around then, but it was certainly not, I don't even know how or why I started to do it. It certainly wasn't now, like now when everything's all over the internet and it's very much influenced by what other people are doing. It must have just felt like something that I needed to do, I guess. So yeah, it was a different...
Back then, did you have anybody that you could confide in, or were there any forums or any kind of information that you could get back then at that age?
There wasn't a lot. I remember sitting on the floor in Waterstones when I was around that age, and sort of secretly looking through all the mental health books on the shelves and, trying to find things that I identified with. I think it was slightly complicated by the fact that my mum was a teacher at my secondary school. So I felt like I sort of had a double pressure to keep things secret, both from the school, because I felt that if school knew what was going on, they'd feel beholden to tell her about it, and I didn't want people to know. Sure. So, no, not really. I had a few friends who I spoke to. They knew when I was started on medication, but there wasn't really anyone that I could have deep and meaningful conversations with about it at that stage. Yeah.
I was hoping to ask you a little bit about your experience of being sectioned and of going to psychiatric hospital, particularly because I imagine there are people that might be listening to this who might be in a similar situation themselves, or have friends or family, and it can be quite daunting, I imagine. Do you mind just talking me through what led up to that and what it was like? Yeah,
sure. So my first admission was, I wasn't sectioned on that occasion. It was a voluntary admission. That came about after a suicide attempt. And I was absolutely terrified. I remember, going in, and my husband was with me, and just sitting at one of the tables in the common area and sobbing because it was just so frightening. That was a fairly short admission. That was 10 days. But I've had, just trying to add it up, I think I've had 5 admissions. That was the first. And yeah, it was really intimidating. It was really scary. I felt, obviously it wasn't his fault, but I felt very abandoned by the fact that my husband then had to leave me. It was, it wasn't a warm welcome, let's put it that way. Okay. I was sort of parked there and told, we'll come and deal with you, in a minute, which ended up being a long while. So yeah, it was a pretty uncomfortable first experience.
And what do you put that down to? The fact that the staff weren't that warm or welcoming? Were they too busy? Was it their bedside manner, or a number of...
It was late at night. So obviously not the same staffing levels as they would have been during the day. And I don't know. During all of my admissions, my overwhelming impression has been that staff always had something better to do than look after me, whether that be paperwork, other patients, medication. So yeah, it felt very, very isolating. And yeah, I sort of sat there for a while, and then they came and took me away to the medical room where they took my weight and blood pressure and ECG and all those things. Had my belongings checked through, and then was taken to my room.
Okay. And that experience of the staff being potentially distant or a bit cold, is that something that you experienced throughout most or all of your admissions?
Yes, all of them, unfortunately. There were, on every admission, there were 1 or 2 people who seemed warm and caring and genuinely enjoyed their job. But the vast majority, I found there was a real us and them mentality. There was not a lot of time for patients. I felt like patients were also often treated quite disparagingly. There seemed to be a lot of judgment, a real lack of sympathy, and also a very real lack of time sort of spent just on the wards, just being with people. Everything seemed to be hidden away in offices and banging on the door and waiting for ages, and then people who wouldn't talk to you if you asked something because they were on one-to-one with another patient. So, yeah, I found very much that we've all almost seen as an inconvenience on the ward.
Yeah, I'm very sorry to hear that you had that experience. To be absolutely frank, it doesn't sound alien to me at all. I've worked on many wards where we've been in the little nursing office and I've come in to do my jobs and I've been busy and we've had patients knocking on the door, and some staff are very good. Some staff will answer the door, politely tell patients, I don't have time to see you right now, but if you tell me what it is, I can see you later. But if I'm being totally blunt, some staff would be very dismissive and actually quite rude to patients, and always made me feel a bit uncomfortable. I have a lot of sympathy.
It's an incredibly difficult place to work. I know that mental health services are so overworked, underfunded. It's a thankless job. It really must be. And I very much sympathise with the staff who were frustrated, burned out. But what I do have a problem with is people who have then sort of stepped so far in that direction that it's become, sort of an active distaste for the job, and almost a power trip over patients in some ways, possibly from feeling unempowered as a part of the system. But yeah, certainly some very sort of controlled and coercive behaviour, and not always very pleasant at all.
Okay, that's a shame. And what about actually being occupied on the ward, entertained? Did you have like occupational therapists, for example? Or were you given activities?
There were. I find it when I'm unwell, I'm very, very withdrawn. So I tended to spend the vast majority of my time in my bedroom, only coming out for meals, really. But yes, there were OTs on the wards. I found quite a lot of the activities were, patronising is kind of the wrong word, because for some people on the ward, making smoothies, doing a bit of gardening, doing a quiz would have been really helpful. But because I'm always sort of quite high functioning, I didn't really need to be taught how to make a cupcake, and wouldn't have found that therapeutic. So yes, although there was a presence, it didn't really provide me with what I needed. And it also seemed to be a bit unpredictable as well. Something would be written up on the board that was going to happen that afternoon and that just wouldn't happen.
Right. And I imagine that's doubly frustrating if you're already quite locked in and time's moving really, really slowly. You're probably looking forward to events or situations.
Yes, definitely. Yeah.
Okay. In the wards that I've worked in, I've seen a real big mix. So I think because latterly, I've worked in forensic wards that would tend to have a lot more resources. The patients are in for a lot longer. And generally speaking, there's more of a psychology presence and an occupational therapy presence, just because there's more time, more staff. But I've certainly worked when I was a junior doctor in general adult wards. And sometimes you just walk in and there were these patients that would just sit all day in the lounge, just doing nothing. And it's really heartbreaking. I think it is hard to engage some patients at some times because they might have, for example, negative symptoms of schizophrenia and they might not have much motivation, but you've got to do something. They can't just sort of sit around and wait for mental illness to pass.
Yeah, and I think that's when tempers fray and the atmosphere gets unpleasant on the ward. It takes the slightest thing when people are that frustrated and bored to flip into absolute anarchy. On one occasion, the police was called to the ward and the ward was locked down because a row broke out over whether some patients were allowed to melt chocolate to make crispy cakes, which sounds absolutely ridiculous. But in that sort of environment, the smallest thing is a flashpoint. And that disintegrated into people ripping their clothes off, tables being thrown. It sounds absolutely unbelievable, but the smallest thing can light that touch paper when everyone's in such a pressure cooker environment.
So did you feel, obviously that's one quite harrowing scenario. Did you feel generally safe on the ward, would you say?
Yes and no. So I've been on two different wards. I've been on an acute mixed ward and then a longer stay women's ward. I felt less safe on the mixed ward, perhaps unsurprisingly. Although there were separate male and female corridors, obviously everyone could freely mix then in the communal areas. And although I didn't feel sort of personally threatened in any way, I did find it uncomfortable to be around men, wandering around in their dressing gowns or things like that. Women's ward was better. There was a more of a sense of camaraderie, and I think just a slightly more relaxed atmosphere, being all women. But I think the saddest thing is that I don't find the staff made me feel very safe. I think sometimes it was the opposite. They made me feel unsafe.
In what kind of way?
So to take my last admission, I went out for some leave with my family. We went to the pub for lunch. I had a glass of wine with my dinner. It was lovely and relaxed. My husband brought me back to the ward, and before I knew it, I was being bodily searched for contraband that I brought in. I was breathalyzed. I then went to my room and discovered they'd searched my room in my absence and taken away various bits and pieces. That, a very short phone charger that I had, knowing that I wouldn't be allowed a long one. I apparently had one ibuprofen tablet in my wash bag that must have been left there from a previous holiday, but they took that away. And there were a lot of accusations that I was stockpiling medication to take. And that violation of privacy actually led to me self-discharging, because I just felt so degraded and so unsafe. It felt very much like they were attacking me rather than on my side. I subsequently made a complaint and was told that it was very clear in the behavioural policy that I shouldn't have drunk alcohol, and I never saw a behaviour policy. I mean, apparently it should have been given to me on admission. Never saw such a thing.
So did anybody specifically tell you before your leave that you weren't allowed to have alcohol?
No. And, I had many periods of leave beforehand where, nothing had been mentioned. And I was told that, of course, the staff would have told me as I was leaving the ward not to drink alcohol. And no, not at all.
Yeah.
And again, with the bodily searching, I was told that was policy as soon as someone came back from leave, but it never happened before. So.
Okay. And going back to the patient mix on the ward, was there like a hierarchy or cliques within the patient groups? Do people generally get on, would you say, or how did it work?
Yeah, I mean, it's obviously quite an intense and stressed environment. There were the people who were louder and more gregarious and the more natural ringleaders, definitely. There were people who I think, found it a really mutually supportive environment. As I say, I'm quite withdrawn. I didn't make close bonds myself. But particularly in my last admission, there seemed to be two very strong cliques of very strong women. And some of the arguments, physical arguments between those were quite eye-opening over the smallest thing, accidentally knocking someone's coffee over. I didn't find mixing on the wards very easy at all. Okay.
And are there any positives that you take from your experiences, or any things that you think were done particularly well?
Yeah, I mean, the biggest positive I have to say is that, although being sectioned was horrible and frightening and just felt like the biggest deprivation of liberty, it kept me alive. I think one misconception about certainly shorter stay psychiatric wards is that you go in there, you get loads of therapy and you come out better. And it's not like that. It's a holding pen to keep you safe during the crisis, so you can't harm yourself or harm others in some cases. It fulfilled its objective in that way. I was lucky that the unit that I've been in was very recently built, 2014, I think. So it's very modern, very clean, very well designed so that people could have privacy. I had my own shower, which, although it didn't have a locking door, it had a door so I could go in and not be watched. So I was fortunate in that way. I mean, it felt a bit more like university halls than, some of the old-fashioned psychiatric hospitals.
Sure.
On a couple of admissions, having sort of spent time with psychiatrists on the ward, I came out feeling a lot more hopeful, feeling that my medication had been properly reviewed and I'd been listened to, and that there was a decent follow-up plan. So and although it wasn't always comfortable and wasn't always a pleasant experience on the wards, it did sort of then start me on a new pathway that was followed up then in the community.
Okay, I'm very interested to know what you thoughts about your psychiatrist. So without mentioning any names, presumably you've had a few in your various hospital admissions. Can you please tell me what they were like, what their empathy levels were like, and the ones who you thought were particularly easy to get on with? What was it about them versus the other ones?
Yeah, I mean, I think my broad experience was that most of the psychiatrists were very, very good. They were very willing to take the time to listen. They were sort of interested in a complete clinical history and were open to my opinions and suggestions. And yes, I'd say, there must have been 4 on the wards during my various admissions who I really, really had faith in, and felt like they were doing a great job. There were a couple who didn't. There was the one who had obviously decided he was going to discharge me before I even saw him. And even though I explained that I still felt very unwell and didn't feel safe to go, he essentially told me that being in hospital wasn't helping me and I had to take responsibility for my own actions. And if that meant going home and killing myself, then that was my responsibility. So that was pretty tough. But yes, I mean, to give credit where credit's due, I think the psychiatrists were very experienced and very empathetic and knowledgeable in general.
I think one of the issues that some psychiatrists have, and certainly that I had when I was working in secure psychiatric wards, is that there's just not much time and there's so much paperwork to do. And I would like to think that I didn't do this, but I certainly know of some psychiatrists who barely saw their patients on the ward, and especially if they're long-term patients that have been there for years and likely will stay there for years with very little change in mental state, it's quite easy to not really review them or to review them very superficially. Did you get that kind of experience with any of your psychiatrists or any of the staff, really?
Yeah, I mean, that the psychiatrist that I mentioned just then, who'd obviously settled on my discharge without even sort of having taken a clinical picture on that day, was presumably time-starved and aware of the pressure on beds, and no doubt had a queue of people waiting for the next available one. And yeah, obviously therefore hustled me out before I felt I was ready. But yeah, I mean, it's interesting actually, because I recently spent some time in an acute day treatment unit, and the difference in what the medical team were able to provide there was staggering. So whereas in hospital, it was one ward round a week if you were lucky, and quite often it might be 10 days. And then if a bank holiday fell in there, it would be another skip day. In the HTU, the day treatment unit, I saw the same psychiatrist twice a week. He got to know me, he respected me, listened to my opinions. So I think it's noticeable that psychiatrists in the community probably have a lot more time to spend getting to know patients than in the inpatient setting.
Okay. And you mentioned about being discharged early on that one occasion. Generally, for your admissions altogether, do you feel that you were ready when you were discharged with it? So not just in your mental state, but also in the support that was provided in the community?
I'd say it's been about 50-50. On some occasions, I felt like, yes, the time was right. And I felt like I was confident in the support that we put in place in the community. Other occasions, I've pretty much begged them to keep me in, saying that I felt unsafe, and have been discharged anyway. My last admission, as I mentioned, I self-discharged after these sort of distressing experiences with being body searched and breathalyzed. And I think my husband was very, very wary about that, because we sort of both had to sign to say that it was our choice and that essentially he had responsibility for anything that happened thereafter. But he did agree that it was probably the right course of action. And actually, I'd been so distressed by my experience on that occasion that although I still felt very unwell when I came out, I was sure that home was the right place to be.
Okay. And right at the very beginning of this interview, I touched on the fact that you were self-harming. That's part of your kind of history in your presentation. I know it's a very personal question, but do you mind just talking us through how that started and what kind of triggers or situations would be associated with it?
Yeah, so like I said, I started when I was a teenager and I didn't really know where it came from. I think probably earlier than that, actually. I would sort of sit in my bedroom and, hit myself with my hairbrush hard enough to bruise. And like I said, this was before the days where you could find self-harm support groups online and things like that. So I don't really know where it came from. It must have come from, deep inside me somewhere. And that kind of escalated, I guess. I never needed treatment for my injuries when I was that age. But I've been in a fairly poor cycle of mental health probably for about the last 6 or 7 years. And self-harm has become increasingly regular and increasingly more severe over that time. It's really, really hard to point out a trigger. I think some people self-harm quite impulsively, whereas I'm sort of quite a planner. I will know that I want to do it. I will go and buy the means to do it, and I will, do it rather than just suddenly losing my mind and doing it in the heat of the moment. And it's really hard to say in terms of what I get from it. It's I think it's a funny combination of release, self-punishment, possibly distraction from my feelings in the moment by channeling it to physical pain rather than mental pain.
Yeah.
So yeah, it's a real complicated thing. And I think what people who haven't self-harm don't necessarily realise is that it can become really quite addictive.
Right.
And that's where you get into the cycle of doing it more and more often and more severely, because what you did before just doesn't seem enough anymore. And at that point it becomes quite dangerous.
I suppose that's the earmark of most addictions, isn't it? That your tolerance rises, so you need to keep going. Yeah, I've heard patients tell me in the past that they self-harm just to release like a distress, and they feel that if they don't, then it would build up over time and probably come out in a more aggressive or more violent way, or severe self-harm.
Yeah, I think that's true. I think it's probably one of the most liberating things I've ever had a psychiatrist say to me, actually, was that although it wasn't a particularly healthy coping mechanism, it is a coping mechanism. And she actually said, we'll park that for the time being. We'll focus on the suicidal behaviour because that's the more pressing concern. And actually self-harm, although, it can obviously be dangerous, it can go wrong, but she was sort of quite respecting of the fact that that was a coping mechanism rather than, a lead up to a suicide attempt. And that really helped, actually. It really helped sort of take the pressure off that situation. I felt understood, and I didn't feel like, I guess I felt like they weren't sort of whipping that coping mechanism away from me.
Sure.
It was still there and it was still valid, and she recognised that, that there were reasons for me doing it, and actually they might be self-protective reasons, which sounds a bit contrary, but actually, yes, if self-harming, like you say, stops you injuring yourself in a more serious way, I'm talking about suicide attempts, then obviously, although it's not ideal, it's better than the alternative.
Yeah, and I suppose the last thing that you want if you're already quite distressed and frustrated is some authoritarian figure that doesn't even know you telling you, no, you're not allowed to do this.
Yeah.
Yeah. So you've obviously been quite open about your mental health issues. You've written a number of articles, which I've read and was very interested in, which is why I contacted you in the first place. Have you experienced much stigma?
Yes and no. I think most people are very supportive. I came out, if you like, on Facebook probably 5 or so years ago, just because it had got so exhausting, keeping it all in. A few people knew, but it was so exhausting. I felt like people in the school playground were judging me for being aloof and superior, where I wasn't at all. I just couldn't talk about it. I couldn't talk to anybody. So yes, I did the big cathartic post on Facebook, and I was staggered by how supportive the vast majority were. And
were these your friends, or are you talking about random people as well?
No, friends and acquaintances. So this was my personal Facebook page. So, and this was before I'd started. I was blogging, but this was before I'd started writing on a professional basis about mental health. There was one person who turned against me in a very unpleasant and destructive way, and I never quite got to the bottom of that. I certainly did an awful lot to try to make amends in terms of buying cakes, buying flowers, sending cards, trying to smooth things over. But for some reason, the minute she knew that I'd attempted suicide, that was it. Not only was I out of her life, but there was some quite unpleasant actions towards me.
That's the opposite of what you need in that kind of time.
Very much so, and I never really quite understood it either. I didn't know whether she was threatened by it or by me, or it's still not something that I've unpicked. I don't suppose I'll ever get to the bottom of that. There have been repercussions in other areas. I had to put voluntary work on hold for a while because I was seen as a safeguarding risk, even though I've never, ever had thoughts of harming anybody else. I'm a mum of 2. So that was really hurtful. I was doing voluntary work with children and was told that I wasn't allowed to continue.
Wow. And
that was really, really hard. And that made me feel quite a lot worse at a very low time as well.
And was there any kind of assessment or leeway there, or was it just a very definitive, no, you're not allowed to work in this area?
No, and it was. I had a meeting with the people involved, and they set out their reasons why they thought I was unsuitable for the work, and that was it really. And that's left me with some sort of quite deep scars. That felt very, very hurtful because it was something at that time that gave me purpose as well. It's being able to volunteer. It made me feel like maybe I wasn't completely worthless. Yeah. So to have that taken away as well was very hard. But overwhelmingly, people have been really supportive, and I'm very, very blessed.
Okay. And going back to some of the experiences that you had in hospital, apart from the very obvious things that you've already talked about, so staff being nicer to you and being engaging, more activities on the ward, have you got any kind of thoughts about how the whole experience can be improved for patients?
Do you know, I think it's just the little things. I think, like you said, when you've been working on wards and some people will open the office and say, really sorry, I'm busy at the moment, come back in 10 minutes. And it's those people who make you feel more valued. I just found that there are, and I think people who've been on the wards at the same time as me would agree with this, but just a whole string of sort of microaggressions, if you like, of things that are done. It almost feels like willfully being done to frustrate people. So, for example, you have to hand in your mobile phone to be charged. Often you go back 4 hours later and they haven't put it on to charge. And obviously, when you're in a hospital, having your mobile phone is an absolute lifeline. And through to just little things like letting you into the laundry. You go and ask and they say, I'm busy, come back in 10 minutes. And, 3 hours later, they're still busy and you still haven't been let in. It's the people who take the time. And, there were a couple of nurses who were really genuinely kind and would come in and have a chat with me in my room. Obviously concerned if I wasn't coming out and wasn't eating, then would offer to bring food to me. It's those people who just make you feel valued. And I guess I think something that I haven't talked about is that I don't know whether this is the case on most psych wards, but certainly when I've been in, there's been an awful lot of agency staff. Yeah. And I guess they don't make the same relationships with their colleagues or with their patients. And I guess a lot of them are probably very poorly paid and so don't particularly see why they should engage or why they should go the extra mile for anybody. And there would sort of be a cast of constantly revolving characters as well. So you'd see someone on the ward one day and you never see them again. And then there's somebody else who comes in.
I was just thinking that actually, as you were talking, I've certainly worked in jobs and units where the turnover of staff is ridiculous. Like even within the space of a few years, you've had 3 or 4 people in the same position and they just shuffle and they leave.
My admissions have spanned probably a period of about 5 years. And I think my last admission, there was possibly 1 or 2 people on the same ward who were there at my first admission. Out of a team of, I don't know how many, but a lot. I think having longer standing people on the wards would definitely improve relationships with patients, but it's a vicious circle, isn't it? If they're being poorly paid and feel undervalued themselves, then what incentive have they got to stay around? So.
Yeah. And especially when the funding for mental health services is disproportionately low, it's not an easy fix. Yeah. So I've got a couple more questions for you, if that's okay.
Yeah, go for it.
And I'm glad to hear that you're well now and that you've been stable for quite a while. Are there any particular factors recently that have kept you well?
It's really hard to say. I don't feel like my low periods ever have a specific trigger. And it's something that frustrates me, and I think it frustrates mental health professionals as well, because they feel, and I feel like I should be able to say, oh, this happened, and that's why I'm feeling so unwell. But it comes really out of the blue for me. So it's sort of difficult to say what I do to keep stable. It feels a bit like a bit of a magic mix of medication and pure luck, really. But as I'm lucky, I've got really supportive friends, really supportive family. My husband's obviously been working from home throughout lockdown anyway, but generally he's been able to work from home when I've been very unwell and, almost babysit me, which I don't necessarily appreciate at the time, but he works very, very hard to keep me safe. Sure. And I think I do attribute a lot of my current stability to medication. It's something that's been changed, doses and types many times over the years. Yeah. Some of my biggest crises have undoubtedly been triggered by medication changes. Right. In 2019, I had quite a long period in hospital, which I strongly believe was triggered by me trying to, with medical advice, but trying to reduce one of my antipsychotics, which made me really quite unwell very quickly. Right. So, and I think, there are lifestyle things, of course. I have to push myself to be sociable sometimes. I find it very, very easy to think, oh, well, so-and-so's only texting me because she's a nice person and it's the nice thing to do and not because she actually cares about me. And I have to really sort of make a conscious effort to put those thoughts aside sometimes.
Yeah.
But yeah, it's a funny one. I really do wish that I could pinpoint something that triggers these lows. It would be lovely to think, oh, well, that's what does it, and I won't do it again.
I suppose if the answer was that easy, then you wouldn't need psychiatrists, right?
I probably wouldn't, would I? No. And it's funny, it seems really unrelated to things. I actually feel like I've coped really well with this period of lockdown, which is just bizarre to me because, it's on paper, it's been awful. I've had my children homeschooling for weeks. I've not been able to see friends and family. My husband has had changes in work circumstances that have been quite difficult. And actually, all the criteria were there for me to fall apart completely. But actually, I've coped really well. And who knows why that is, but I'm very thankful that it's occurred while I'm in a good period.
Yeah. Well, I'm glad to hear that's been your experience recently. So my final question, which is connected, would be, do you have any advice for anybody going through mental health issues?
I think be persistent is probably the thing that I would say more than anything. Whether you're under the care of your GP, whether you're under secondary services, whether you're an inpatient, I do feel like it's the ones who shout loudest who get the help quickest.
Right.
And that's, obviously that's absolutely right. The sickest patients should absolutely get priority in terms of appointments, beds, everything they need. But I think my experience would have been very different if I hadn't had my husband advocating for me. So yeah, I would say to anybody who has that support around them, whether it's a partner, parent, sibling, friend, use them, because sometimes your voice on its own isn't enough and you need somebody else to shout for you. And don't give up. It's really, really hard. When you're in hospital and feeling like no one's listening to you, or when you're in the community and your psychiatrist who's promised to see you in 2 months' time then suddenly leaves, which has happened to me lots and lots of times. It's really destabilizing. Yep. It's ironic, really, because when you're at your weakest, you need to be at your strongest in terms of fighting for help. In an overstretched service, it doesn't come easily. And you have to be prepared to sit it out. And often I think there's things are done by pathway. If you've tried this medication, so then we'll try this medication. And okay, you suggested this medication, but because it's not on the pathway, I don't want you to try it. And actually, it can be quite frustrating negotiating that. So I think persistence. And I think informing yourself as well as much as you can. It's obviously hard if you're having thought disorders, if you're psychotic or hallucinating. Becomes very, very hard then to know what's real and what's not. But I feel like I've done better with psychiatrists when I've been able to do a bit of research, have a bit of insight into what I think I might need. One of the medications that I'm on at the moment, which I think has made me more stable than I've been in years, was something that I had researched myself, and my psychiatrist was quite reluctant to try. But after listening to my arguments, he was agreeable to try me on it. And that was about just over a year ago. And with the exception of a couple of blips, I've been most stable I've been in years. So I think, it does pay. And if you don't feel up to researching things yourself, looking into it yourself, then let a family member do it. If need be, get an advocate. Use your CPN, if you're a community psychiatric nurse, your care coordinator if you've got one. They can be extremely helpful. But it's really hard because I know a lot of people who are suffering from mental illness feel very alone, whether they actually are completely alone or whether it's the illness that makes them feel like that. But it's a really hard journey to negotiate on your own. And I think anyone that you can get behind you will be a huge support. Okay,
that's really helpful. I hope that advice is heard by anybody who needs it, and I hope that listening.
Oh, my last really practical tip: if you're getting admitted to a psychiatric unit, buy a phone charger that's that long, because then you might get to keep it in your room. Whereas if it's long enough for you to do any damage with, you're not going to have it.
Okay, inside information just on this podcast.
Absolutely, yeah.
Lucy, it's been really interesting to talk to you and hear your experiences. Thank you very much for joining me. And I wish you all the best.
Thank you.
Goodbye.
Bye.
So I would like to talk to you about life on a psychiatric unit. To put this into context, I've worked on wards in Sydney, in Scotland, London, and Essex as a junior psychiatrist, and then as a specialist registrar, which is like a middle grade doctor, and more recently as a consultant. I've worked in private hospitals as well as for the NHS. And during my training, I would rotate wards usually every 6 months or so. And on top of that, I've worked on call, where I would deal with emergencies on other psychiatric wards out of hours, sometimes even across different hospitals. So what I'm saying is that I've worked regularly as a member of staff in around, I'd say, about 20 to 25 different wards. And if you include my on-call commitments on top of that, then I've probably worked across about 70 different wards. There are many different types and classifications of psychiatric ward. The most common type of ward are general adult wards, and they deal with a range of mental illnesses. Commonly, you might see things like schizophrenia, bipolar affective disorder, schizoaffective disorder, severe depression, and anxiety. And don't worry if you don't really understand what all of those things are, or if you don't know the details of the symptoms. I will make future podcasts about them. Another common presentation is people coming in for observation after suicide attempts or self-harm, like the case of Lucy. And these general adult wards tend to be either male, female, or mixed. Some wards are actually categorized by the patient's mental state. So the most notorious would be the PICU, PICU, which stands for Psychiatric Intensive Care Unit, not to be confused with a Pediatric Intensive Care Unit, which I believe is also sometimes called PICU. But the psychiatric PICUs are for the most agitated patients, the patients that need rapid treatment for their acute symptoms and they need to be sedated almost immediately. They tend to have quite a high turnover. So on the opposite end of the spectrum would be the rehabilitation wards, rehab wards, and they are for patients who have a long recovery process. So they're not necessarily acutely unwell when they're on these wards, but they have very complex needs. For example, very complex drug and alcohol issues or severe trauma from childhood. And so their rehabilitation needs are such that the patients have to be there for months and sometimes even years. Some wards are classified according to the age of the patients. So you might have old age psychiatric wards, for example, where patients typically might have dementia. Or on the other end of the spectrum, you can have adolescent units, where typically younger people present with deliberate self-harm, behavioural issues. And then some wards are classified by their diagnosis. Specialist eating disorder units would be a good example of these. There are only a handful of those in the UK. Another example of a ward that is filled with a particular diagnosis are learning disability wards, where patients have pathologically low IQs and they might have specific disorders such as autism. I talked about autism in my last episode if you want to have a breakdown of how that presents. And the patients on these wards, they need a very high level of support for everyday functioning and just their day-to-day life. The wards where I've personally been working in recently as a consultant forensic psychiatrist are locked, secure psychiatric units. And as I mentioned before, they're usually reserved for people who have committed serious offences, typically violent or sexual offences, and they're very dangerous. They're a risk to society, so they have long-term rehabilitation needs. In terms of the physical structure of wards, most wards have like these long corridors with individual bedrooms. And most modern wards have en suites for the bedrooms. Some of the wards in deprived areas near Sydney where I used to work had these big dorms with like 8 people sharing beds in one room, and it wasn't even a big room. To me, it felt like a prison or like a backpacker's hostel without the freedom of being able to leave and hop on a train to go interrailing. Personally, I don't think that setup was very conducive to recovery, and it's just not good enough in my view. I think patients need their own privacy and they need their own space to chill, both physically and emotionally. But I'm glad to say that those kind of wards don't exist anymore, certainly not in the UK. Most psychiatric wards have communal spaces, so there tends to be like either a TV lounge and a dining room. Some wards have games rooms, some have pool tables, tennis tables. Generally, most wards will have a few interview rooms and therapy rooms for patients and staff to meet, either one-to-one or in small groups. Most psychiatric units have canteens or cafes, or they might have an art studio, might have a kitchen for patients to cook, might have gyms. Generally, you don't have all those resources on an individual ward, but you'll have one or two in the whole hospital, and they're shared across different wards, which is also a chance for patients from different wards to socialise. Some wards, especially forensic psychiatric wards, have a seclusion room, and that is what used to be called a padded cell. So that's reserved for very agitated patients who just literally cannot be managed on the ward. So they're locked inside this room for their own safety, and mostly for the safety of others. Actually physically going into seclusion rooms to review disturbed patients is a big part of being a forensic psychiatrist. And I've got lots of stories and cases about this, but I'll have to leave that for another podcast. Also, there tends to be a range of different patients with a range of different presentations. I have to say, I'm not at all a fan of the depiction of mentally ill patients on TV and in films. They always seem to be these like dribbling wrecks that are rocking and shuffling, and I think it's damaging, I think it's judgmental, but more importantly, it's just inaccurate. The truth is that psychiatric patients are very variable in their presentation. So some might be quite quiet, might be reserved. Some patients typically stay in their rooms and barely come out. They might be depressed, for example. They might be paranoid. They might have the negative symptoms of schizophrenia, like social withdrawal, or they could just be shy. Some psychiatric wards can be intimidating places, so their reservations might have nothing to do with mental illness. It could just be their natural personality. On the other hand, sometimes some patients are disinhibited. They might be loud, they might be a bit kind of shouty, they might be over-familiar, and these kind of presentations are typically seen in periods of mania. Some patients will be actively psychotic. I mean, that could be the reason that they're there in the first place. So they might be hearing voices, for example. And other patients might actually be very stable. They might be well. So, for example, they could be at the end of their recovery journey, or they're just on the ward for some respite rather than because they're presenting with acute mental illness. And also because mental illnesses tend to fluctuate. The atmosphere on some wards can be tense at times, to be frank, especially on forensic psychiatric wards where you have people with a history of violence, and there are occasional fights. There are occasional incidents where patients become agitated, and this could be directly due to mental illness, for example, paranoia or hearing voices, or it could be because of beefs between patients, could be because of bullying, could be because patients have fallen out with staff members. A typical scenario would be a patient who's had their leave stopped because they came back late or because they breached boundaries on wards. But I think it's also fair and necessary to highlight that there can be friendships and camaraderie on wards. Staff and patients can get on very well. There tends to be a bit of banter at times. I've seen lots of situations where younger patients look out for older patients or vulnerable patients, like buying them cans of Coke from the shop, for example. I've seen on many occasions patients that come in not knowing each other but actually becoming friends during their admissions and going out on leave together. I've seen patients who have made lifelong friendships with people they've met during hospital admissions. And I have to say, it's really nice to see people who come through the system who might not have much in terms of external support structure, but they support each other in hospital. So in terms of the staff that you would see on a psychiatric unit, the frontline staff who commonly do the most face-to-face or one-to-one interactions with the patients are undoubtedly the nursing staff. And I would include healthcare assistants in that category who are similar to assistant nurses. They usually hang out in a nursing office, which is like a fishbowl in the middle of the ward. And the nurses do things like they facilitate groups for patients. They look after possessions and money for patients who are vulnerable and could be exploited. They have one-to-one chats with patients. They support them, see how they're doing on a daily basis. They dispense medications. They might have to do one-to-one observations on patients who are deemed very high risk of either harming themselves or attacking other people. And then you have psychiatrists such as myself who are usually identified in our suits or our shirts. We usually look quite flustered and are busy. And contrary to popular belief, very few of us have beards or bow ties, and hardly any of us smoke pipes. Psychiatrists tend to be busy. We tend to have other responsibilities, such as other patients across multiple wards. We have outpatient clinics to see patients in the community. We have a plethora of meetings and an endless stream of reports for patients. And also we supervise junior doctors and nurture the next generation of psychiatrists. Psychiatrists generally are not based on the wards, but they come onto the ward regularly, and the frequency might depend on the complexity of the patients and, if I'm being honest, the work ethic of the psychiatrist. Generally, psychiatrists tend to take the ultimate clinical responsibility for the patient, so we make the major treatment decisions. We prescribe the medication, we sign off on patients' leave, we decide when they're ready to be discharged into the community, we see who needs one-to-one observations, and we also decide who needs to go to the seclusion room and when they're well enough to leave. A good psychiatrist should take counsel from the multidisciplinary team, the other staff members who work with the patients, nurses, who I've already mentioned, psychologists, occupational therapists, who I'll talk about later, social workers, and these minds conglomerate in a big meeting, which is called a ward round. And during these, each patient is discussed at length individually, and then sometimes we see the individual patients to elicit their views and their concerns about their progress and their treatment, and to discuss their requests. These ward rounds often can take all morning, and if you've got a complex mix of patients, they can sometimes take all day. Another key member of staff are the occupational therapists. They coordinate activities, and this can be anything from educational sessions to cooking skills to newspaper groups, going to the gym, gardening, financial skills. I've even seen dog walking groups in hospitals that I've worked at. And the job of the occupational therapist is to rehabilitate patients and get them ready for life in the community after discharge. So, for example, to help them with their vocation, they might help them write CVs, they might get them work experience in local shops or voluntary work. And then there's the psychologists. Psychologists are very often mistaken for psychiatrists, and there are many differences, and maybe one day I'll do a separate podcast to cover these. But briefly, unlike psychiatrists, psychologists generally have the luxury of time, of being able to sit down with their patients for extended therapy sessions where they can talk to them. And this is either one-to-one or it can be in groups. And they tend to talk about very specific problems to that patient in depth in a structured manner. So, for example, on a psychiatric ward, typically a psychiatrist might talk to a patient about hearing voices and gaining insight into this and other symptoms. And also about relapse prevention. So that would be the psychologist sitting down with the patient together, figuring out the various factors and strands that led to the patient's relapsing, or if it's the forensic psychiatric ward, led to their offending, and trying to minimize those factors for the future. There are rules on wards: no shouting, no bullying, no smoking, no sharp objects because of potential self-harm, no borrowing to prevent exploitation, no drugs, no alcohol, no heavy petting. Oh no, wait, that's swimming pools. And if the rules are broken, then there can be consequences, such as having your leave stopped. Most psychiatric wards are locked. If there are voluntary patients, also known as informal patients, that is patients that are not sectioned or detained under the Mental Health Act, then they can leave whenever they want. But they should coordinate this with the nurses so the nurses know where they are and know that they're safe. Most patients are sectioned, and they can have leave, but this has to be formally agreed and signed off by the consultant psychiatrist. And usually that decision depends on their symptoms, on their behaviour on the ward, and leave tends to be increased incrementally. So what I mean by that is it starts off as a small dose, maybe 15 minutes of escorted leave on the ward, but still on the hospital grounds. And then if that goes well, the time period is increased. The patients are let further afield into the community with escorts, usually one, sometimes two nurses. And if that goes well, then they eventually get unescorted leave, which is also gradually increased over time if the patient is stable and is engaging in treatment and if their behaviour is not problematic or aggressive on the ward. Now, I just want to say that the vast majority of patients use leave appropriately the vast majority of the time. However, occasionally there are boundary breaches. Patients come back late, or they come back smelling of alcohol, or they've used drugs on their leave, and there are consequences. Typically, when this happened, leave is stopped for around 2 weeks. So in terms of what works well, I think a good ward has a sensible patient mix. What I mean by that is they're not mixing too many acutely unwell patients together, which might increase the risk of agitation or of assault, but also not mixing vulnerable patients with, for example, patients with personality disorder, which means there could be a risk of exploitation. And a good ward has good staff attitudes. Lucy talked earlier about how this is very variable. And I have to say that I've personally worked with staff members who've been enthusiastic, well engaging, friendly and supportive towards the patients, and have spent a lot of time with the patients. But I've also worked with staff who tend to be on a power trip, to be frank. They can be authoritarian, they can be rude, they can go way beyond setting necessary boundaries. Some staff members don't prioritise their patients and they get drowned by paperwork and they're just sort of stuck in their office all day. As a side note, I actually quit my job on a psychiatric ward a few years ago and then went to work in a large women's prison instead. I was just being overwhelmed with paperwork, and that was one of the main reasons I quit. I was just bombarded with bureaucracy, and I found less and less time to spend time with my patients, which is ultimately why I became a psychiatrist. But anyway, that's another story, and that's for another podcast. I've also worked with lazy staff, I have to say, who do the absolute minimum, whether it's undertaking therapy or making arrangements with outside professionals to arrange work or to arrange discharge for a particular patient. And I think this is ultimately down to their personal work ethic. But unfortunately, it's detrimental to the patient because the ultimate result is that it delays the patient's discharge and keeps them longer in hospital than is necessary. Good wards have a lot of activities. Patients are, I'd say that they're more than encouraged, but less than bullied, pressurized. Let's just say they're kind of pressurized into indulging in activities. And a well-oiled ward has a good psychiatrist. A good psychiatrist listens to their patients about medications and about leave requests, but a good psychiatrist also has firm boundaries. So if a patient does something that's out of order, then the psychiatrist should call them up on it. A good psychiatrist is not easily bullied or intimidated by patients. And, to be fair, some patients can be intimidating, especially on forensic psychiatry wards where they have a history of violence and offending. Also, a good psychiatrist listens to his or her other members of staff that make up the multidisciplinary team, and they don't make unilateral decisions. A good psychiatrist is present on the ward and is proactive in getting their patients better. I've worked in a previous job where I've taken over from a predecessor who was very passive in her reproach. I mean, she just seems to have done very little for her patients over the years, and they hadn't really made progress. And to be honest, I was shocked when I took over. So what makes a bad ward? A bad ward, like most places of work, staff are not happy and they're constantly leaving or they're constantly off sick. And there's a massive kind of turnover of staff, which is particularly harmful for the patients because the patients then have to tell their traumatic stories again and familiarize themselves again and form new bonds and trust with a constant stream of new staff, which is just not helpful. A bad ward is understaffed with nurses in particular, and the nurses that are there are bogged down with paperwork to the point they're just too busy to spend quality time with their patients. Nurse recruitment in psychiatry is a massive issue across the UK, particularly in some specific geographical areas. Personally, I don't think nurses are paid enough, but that's a whole different podcast. A bad ward has very little in terms of opportunities for patient activities, and the patients just sit around looking bored all day. And a bad ward has poor or inconsistent boundaries, and there's lots of assaults on both patients and staff, and there's no safety protocols, or if there are, they're not followed properly. A bad ward has no psychologists or occupational therapists. I've actually worked on wards where there hasn't been either of those members of staff in the team for the whole time I've worked there. Arguably, a ward can just about function with nurses and psychiatrists because patients can be treated, they can be medicated, they can be observed, they can be eventually discharged. But I would argue that for actual rehabilitation to be undertaken efficiently, you need to have a psychologist and an occupational therapist. And finally, a bad ward has bad leadership. And the psychiatrist is the head of the multidisciplinary team, so that person has to take responsibility, in my view. Now, that was a lot of information. I hope it was helpful. I hope it was interesting. As I said before, I do plan to make a whole series of these podcasts, both an audio version and also a video version for my YouTube channel. I'll be addressing a whole range of topics related to mental health and related to the human condition, some in regards to offending and violence, though some not. And I will interview various people from ex-patients to members of staff. And most of all, I'd like to share my stories. I'd like to tell you about the more interesting, unusual, and at times gory cases that I've come across in my career as a forensic psychiatrist. Next episode is going to be about delusions. I'll tell you what a delusion is. I'll go through the different types like paranoid delusions, grandiose delusions, and I'll be telling you about a few specific criminal court cases where I've personally been involved in, where delusions has led to violence and offending. This includes a psychotic man who believed he was the 13th Sikh guru, and he believed that his IQ was greater than Einstein's, and he went to a Sikh temple smoking a joint, and he tore out the pages of a religious book, and he got chased into the cinema by everyone who was there, and he got beaten up. The whole thing was a mess. And I'll also tell you about a young woman in her early 20s who went with a machete into a flat full of people who were apparently drug dealers and stabbed one of the main dealers, leaving a huge gash across his chest. Now, I say apparently drug dealers because it was really hard for me to distinguish the truth from her delusional beliefs, and I'll dissect that a bit in the next episode. So please subscribe to our YouTube channel, follow us on Instagram, like our Facebook page, and submit an episode idea to our email, which is psychforsoreminds@gmail.com. Hit me up on social media to ask me any questions about this episode or any other episode or anything about forensic psychiatry. I'll be happy to talk to you. So I hope this podcast floats your boat. Stay tuned, and I hope to catch you again soon for a Psych for Sore Minds. Until then, stay euthymic, homies.